So good evening and welcome. I'm absolutely delighted to see that we've got so much interest in the talks and session this evening, and really quite sad that we're not all in the room. I think there are over 100 people signed in to this evening. We're particularly going to miss the company and the discussions that inevitably flow on from these sessions, but needs must, and here we are. Just a little bit of housekeeping before we get going. There is a Q&A for those on the Zoom meeting. If you could type your questions into there, we'll feed them through and we will be addressing them. And the way we've got a mixed meeting tonight with some people in the room and others, most of you out on Zoom. So before I introduce our keynote speaker, who's Dr. Rick Brennan, I'd like to just set the scene very briefly to talk about how we got here today. So as many of you are probably well aware, trauma services were substantially organised across the UK nearly 15 years ago now, on the back of a whole series of papers and various bits of work demonstrating there had been absolutely no changes for patients suffering from major trauma in the UK in the previous decade, as well as improved outcomes for trauma patients in healthcare systems where trauma services were systematically organised and where major trauma itself was recognised as a disease entity in its own right. In 2012, Addenbrooke's Hospital became a major trauma centre at the heart of a trauma system covering the entire of the east of England. And at that same time, 26 major trauma networks were set up, pretty much covering the entire of England and covering all of adult and children's services. Addenbrooke's, of course, is uniquely positioned. We're within the University of Cambridge, and we have a plethora of world-class research groups, many of whom work across the arenas of global health, systems research, quality and safety, within healthcare and within medical education. And these are often aligned alongside more traditional-based academic work and clinical work. Simultaneously, Addenbrooke's Hospital was uniquely supporting the development of Addenbrooke's Abroad, now Cambridge Global Health Partnerships, with the aim of delivering sustainable medical education and service changes through established partnerships within hospitals and universities in a number of countries across the world. They've had a particular focus in ensuring NHS staff have the opportunity to become involved in such work, including academically. Well recognised to deliver added value to all systems, as well as developing and challenging personal and professional lives, and almost invariably with the added benefit to patient care and staff retention within the NHS. Much of this work has been funded through organisations like the THET Healthcare Partnership Scheme, as well as enormously generous donors and charitable organisations. For our local group, we've been particularly lucky to be part of all of the above. Most recently, we've spent much of the last 6 years working with partners in Myanmar, and particularly with colleagues in the Yangon General Hospital and Cambridge University Hospital clinical departments of anaesthesia, intensive care, neurosurgery, pathology, nursing and physiotherapy, and collaborating with the Department of Systems Engineering led by John Clarkson, a truly multidisciplinary and highly effective collaboration. We are embedded within the NIHR Global Neurotrauma Group led by Peter Hutchinson and David Menon. The work in Myanmar has covered a large range of areas, but of most significance in recent years has expanded as a significant and fruitful research program focused on understanding systems of trauma care in Yangon, as well as countrywide, in what can best be described as a particularly challenging international arena. Our research has involved local researchers embedded in our programs, as well as UK researchers, and with a substantial academic output, utilising both traditional and perhaps less traditional academic paradigms. It has also, and just as significantly, resulted in a range of humanitarian outputs, which has placed us well to support Yangon medical colleagues who were particularly affected during the current military coup, as well as during the pandemic. Alongside our work in Myanmar, CGHP have had a long-standing relationship with colleagues in Uganda, some of whom I know are on the call tonight, but primarily infectious diseases and women's services. More recently, we're working to help them evolve intensive care services and working very closely with them. Developing academic ties is embedded within this. Many of you, I hope, were able to join the Uganda-UK Ground Round held earlier today, and Arthur Kwizera, who has recently completed a PhD here in Cambridge, will be talking about his experience of the collaboration following on from Rick. We're truly excited at the prospect of working with Rick Brennan and the TOPAT team. Indeed, the work has already started. We've had an HE Global Health Fellow working with the team for the last 6 months, and CUH researchers led by Tom Bashford have been gaining an understanding of the potential for data collection systems and wider functioning of TOPAT in an effort to clarify our focus. There's no question that using systems approach combined with other methodologies aiming to understand and deliver improved healthcare across the sphere of activity of the TOPAT group has the potential to deliver significant benefit at a global level, some of which will be locally applicable, but much of which will provide the base for understanding and improving trauma management worldwide. So today and this afternoon, we've had a rather intense but really productive afternoon and hugely enjoyable working through some of the operational aspects of this collaboration and really trying to evolve the vision for how we're going to work together, and not least of which meeting each other face to face after all this time. I've also discovered that Rick and I have a university in common, and he was a few years ahead of me, which is really nice to know as well. We've been swapping stories of life in Sydney. So on that note, I would like to hand over to Rick Brennan. So Rick Brennan is the Regional Emergency Director for the WHO's Eastern Mediterranean Regional Office, based in Cairo, Egypt. He oversees WHO's support to 22 countries for emergency preparedness and response, including for the COVID-19 pandemic and for multiple large-scale humanitarian crises, including Afghanistan, Somalia, Syria, and Yemen. Previously, he spent 7 years at the WHO headquarters, including as Director of Emergency Operations, Director of the Ebola Response and Coordination, and Director of Humanitarian Responses. Rick has extensive experience in health emergencies and in humanitarian sessions in over 40 countries across Asia, Africa, Eastern Europe, and the Middle East. He received a medical degree from the University of Sydney and trained as an emergency physician in Australia and the United States. After obtaining an MPH from Johns Hopkins University, he worked with the US Centers for Disease Control and Prevention on humanitarian and civil military issues. Thereafter, Rick spent 10 years as Health Director of the International Rescue Committee in New York, overseeing global humanitarian and health operations. Prior to joining WHO in 2012, he worked with the JSI Research and Training in Liberia, managing a large post-conflict health system support project. So I'm really looking forward to hearing what you've got to say. Welcome. Thank you.
Well, thanks very much, Rowan, and it's a real pleasure to be here in Cambridge. I really do want to thank Rowan and Tom in particular for the invitation to be here, my first visit to Cambridge. And as you said, we've had a full, intense and fun, in some ways fun and enjoyable discussion, and I think we've got a way forward. So we've been focusing largely on trauma today, but I want to take a bit of a broader look at humanitarian issues globally. So let me start. So hence the title of the presentation, because it is complex out there. We have a lot of challenges. But I thought it would be timely to start with this slide. And I took this on BBC this morning. This is a photo of thousands of Ukrainians leaving Kiev in the face of the Russian onslaught. And probably none of us can imagine what those people are going through right now, facing major disruptions of their lives and livelihoods. I worked in Bosnia in 1993, 94, 95. I responded to the refugee flows out of Kosovo in 1999. I was really not thinking that I would see another episode like this in Europe, but it just, again, reminds us why we're all here today. You know, people, civilians caught up in the middle of conflict. It shouldn't happen, but it does, and we need to serve them better. So this is what I'm going to try and address today, just trends in emergency needs and risks globally, how we try to practically deliver humanitarian assistance in some of the most complex and toughest operational environments. I'll address a few specific words related to trauma, and then maybe very briefly how we're addressing COVID in these settings as well. So, you know, humanitarian emergency needs by the numbers. Each year globally, there's about 200 or more major outbreaks on average. There's over around 285 natural disasters per year. Most of this driven by climate events. And currently there's 30 large-scale humanitarian crises as defined by what's called a humanitarian response plan that's funded through an international process. Well over 90% of those are driven by conflict. Currently, across the world, there are 274 million people in need of humanitarian assistance right now. That is the highest number in history. And you can see the global trends here. The top line is what's happening at the global level. The blue line is what's happening in our region. So over the last, 274 million people need humanitarian assistance today. For a variety of reasons, resource constraints, access constraints, we're going to try and reach about 2/3 of them this year. The number in need has increased by 63% in the last 2 years. It's increased by 250% since 2015. In our region, we have 101 million people in need of assistance. That number has increased 53% in the last 2 years and 91% in the last 7 years. And that does not account for COVID. This is just conflict-related displacement and need. So this is our region. It's a tough neighborhood. We extend from Morocco and Northwest Africa across most of North Africa, except Algeria. We include Somalia and Djibouti in the Horn of Africa and Sudan, then right across the Middle East, as far as Afghanistan and Pakistan. We have 13 major emergencies that we're responding to right now. 5 of them are what we call grade 3, all hands on deck. We have 27 other major public health events that we're responding to. So that would include, for example, the ongoing measles outbreak in Afghanistan and the ongoing food security crisis in Somalia. As I mentioned, we have over 101 million people in need of humanitarian assistance. We have 9% of the world's population, but 37% of the global humanitarian caseload. We are the source of almost 2/3 of the world's refugees. In terms of, that's from the conflict side. We are very prone to other types of emergencies. Outbreaks, in addition to the COVID pandemic, we had 21 major disease outbreaks last year. To put things in perspective, in Sudan, in addition to responding to the conflict and displacement in places like Sudan and the South and Abyei, there were 6 concurrent disease outbreaks in Sudan in October 2019, really overstretching the humanitarian capacities. Natural disasters, of course, we've got this big, a lot of them climate related, but we're also prone to earthquakes and technological disasters. You'll remember the port explosion in Lebanon a couple of years ago, chemical weapons attacks in Syria in the past. 4 of the 5 largest humanitarian caseloads right now are in our region, and you can see those on the left. And it's not getting any better. We all know the drivers of risk, and we've seen that today: state fragility, political aggression, emerging infectious diseases. I think you're all familiar with these issues that are just driving humanitarian crises, disease outbreaks, natural disasters. So what are some of the health issues we're faced with in these settings? Well, we often sort of lump the humanitarian emergencies with what we call the fragile, conflict-affected, and vulnerable states, the FCV countries, not all of which have ongoing conflict, but we often sort of lump them together. So these FCV countries have the worst health outcomes. 7 of the 10 countries in the world with the highest under 5 mortality and maternal mortality have some form of ongoing conflict and humanitarian crisis. 70% of cases of epidemic-prone diseases occur in these settings. And of course, conflict displacement has direct impacts such as violent injury, sexual and gender-based violence, mental health impacts, food insecurity and associated malnutrition. But we also see major health system disruption, disturbance and breakdowns of public health and clinical programs across the board, immunizations, disease control, maternal and child health, and so on. Loss of staff, huge brain drain in these contexts. For example, it's estimated in Syria, in the early days of the conflict, 60% of doctors left the country. Attacks on healthcare are increasingly common in humanitarian crises. So much for international humanitarian law and respect for humanitarian principles. In our region in 2021, we had 358 attacks on health, on healthcare, health facilities, health workers. That is 44% of the global attacks on healthcare. Right now in Syria, only 49% of public health hospitals are fully functional. In Yemen, the figure is 55%, and I could give you other examples. So in this context, fragile, conflict-affected and vulnerable countries are seen as the greatest challenge for the world to achieve the Sustainable Development Goals. And they're tough operating environments. There are a lot of operational constraints to our ability to deliver and meet the needs of people. Access to those in need, insecurity, of course, big problem. And as I said, often the belligerents, never heard of the Geneva Conventions, don't know understand the principles underlying international humanitarian law or neutrality, independence, humanity, impartiality. The lack of national capacities, we've mentioned the brain drain. We're often working with national health workers, national NGOs that really have limited capacities to scale up and meet the needs that we face. We develop, there's a huge political dimension to these environments with divided territories and governance. So for example, in Syria right now, there are essentially 4 different territories. We have up in the northwest, which is under control by opposition forces, Islamist groups. We have a section in the northeast, which is under Turkish control. Then further in the northeast, it's under Kurdish control, and the rest of the country is under the control of the government. So we have to adapt our access strategies to those 4 different operating environments. In Yemen, there's a self-declared government in the north, separated from the internationally recognized government in the south. And again, how you engage politically and with health diplomacy in these different contexts is very, very tricky. And I can tell you, I spend an enormous amount of my time trying to address these political issues because they all impact our access to the people in need. And then there are the bureaucratic constraints. These governments that don't have the welfare of their people as their primary objective will often limit our ability to get to those in need. The other big constraint is the decline in funding. There's a lot of humanitarian fatigue, crisis fatigue. You can see, again, the financing needs have gone up over recent years. But the proportion of the funds that we ask for is declining. So right now, this last year, we only got 42% of the money we asked for to support humanitarian operations. And this is a big challenge for us right now in almost all our humanitarian settings. And frankly, the crisis in Ukraine is going to make this worse, because that's going to be another diversion of aid away from other crises like Yemen and Syria and Somalia and Afghanistan and so on. So in that context, how do we approach that? What's our operational strategy? Well, we try to focus on expanding delivery and quality of an essential package of health services with a big focus on the most vulnerable. We try to reinforce the resilience of the health system to withstand other shocks, because as I've mentioned, in these settings, there are often new acute on chronic emergencies, whether it's a disease outbreak, an escalation in violence, an acute displacement. We try to support, the essential elements of the health system, health workforce, information systems, supply chain, and as far as possible, we try to lay the foundations for long-term health system recovery, through development, I should say, through what we call early recovery elements. The good news is, if we get access, we can deliver. So here's little Khadija from Yemen. She's one of our poster children from our successful nutrition program there, where we had a 90% cure rate for severe acute malnutrition in Yemen a couple of years ago. And you can see the before and after photos of Khadija. So we can, in spite of all those challenges, we can do a lot of good. So I thought, to try and capture this, make it a bit more real, rather than giving a whole bunch of examples, I thought I might zero in on what's going on in Afghanistan right now. So Afghanistan, after the Taliban fell in 2021, huge international investment, including in the health sector. Some great work done in the health sector in those first 10 years in particular. And the benefit of that is that maternal mortality reduced by 60%, under 5 mortality by 50% over the last 20 years, thousands of healthcare workers trained, including female health workers. And then there was this great model developed called called Sehat Mandi, or the basic package of health services. What international donors did and the government, they contracted with NGOs to deliver this basic package of health services. And they did that across 2,300 health facilities right across the country. And that's been the main source of health services for about 70% of the population for much of the last 20 years. And it's been a pretty successful model with some teetering in the last couple of years. So, but where are we today? Well, you're all familiar with the events of last year. There's been a skyrocketing increase in humanitarian need there. Right now, as of today, there are 24 million people in need of humanitarian assistance in Afghanistan. That's almost 4-fold increase in the last 3 years. 22 million are food insecure because in addition to the recent conflict and further displacement, there's been a very significant drought. In addition to, there are multiple disease outbreaks. In addition to the pandemic, we have ongoing major outbreak of measles, cholera, dengue. Afghanistan is only one of 2 countries in the world where wild polio virus remains endemic, and there is a risk of resurgence. Last year, we had the fewest number of cases ever documented in Afghanistan. So we've got an opportunity now to finish the job with polio eradication, but with all the uncertainty and instability right now, we're worried about things taking off again. Violent injuries and trauma, I'll show you some more data about that in a moment. Medical supplies, everything that you can imagine that would challenge a health system. One of the problems has been, since the Taliban took power, the development donors paused their funding for every program they supported, including this basic package of health services that I mentioned that supports 2,300 health facilities. So all of a sudden, the NGOs, who hadn't been paid for up to 7 months before the Taliban fell, all of a sudden, any pipeline of money coming from the donors was paused because the Taliban was in power and it was the government that ran this health program. So everyone was talking about imminent collapse of the health system. And of course, the Taliban is not recognized as a legitimate authority by the international community, even today. So we did a health facility assessment. Luckily, through our polio program, we have staff on the ground at every province. Around September, October, we estimated that 96% of the health facilities were still functional. They were still, turning on the lights and opening the doors. Encouragingly, 95% of female health workers were still turning up, but only 17% of them were fully functional, and 77% of them had drug stockouts, and things were getting worse. The trend was going, because we were collecting this kind of data on a weekly basis. So with that enormous range of need, what next? What do we do as WHO? So together with UNICEF, we teamed up and we went, because we knew the development donors, and those of you may not be familiar with humanitarian settings, there are the development donors and then there are humanitarian donors. Development donors have been supporting this package of services. We went to the development, and they weren't going to give us any money. So we went to the humanitarian donors and said, people are going to die unless you give us money now. So fortunately, they did. They gave us money for 3 months. We went out to the NGOs that had previously been running the services. We accelerated the contracts and we turned things around. And we've been supporting these 2,300 health facilities since the start of November. We've been doing these regular facility assessments. Remember, I told you only 17% of facilities were fully functional. Just a few weeks ago, we were able, you can't see the total there, we were able to do assessments on over 900 of the health facilities, and almost 100%. Only in Faryab province was less than 100% of health facilities fully functional. I was there just a few weeks ago. It was really encouraging to go to health facilities in Parwan, see the staff turning up. They'd received their salaries for the first time in 7 or 8 months. There was heat going on in the health facilities, and there were drugs in the health facilities. So we are continuing with this program through till about July. and we're hoping then that there will be longer term funding through the World Bank. As I mentioned, so that was our big priority. Our second big priority was to get on top of the disease outbreaks. This measles outbreak, you can see, is just really taking off. Only less than 60% of kids in Afghanistan are vaccinated, but we've had over 40,000 cases in the last year. So in December, we did a risk assessment, worked out what the worst provinces were. We vaccinated 1.7 million kids. We've just done another risk assessment. Next month, we're targeting 3.5 million kids across 27 provinces. Polio, luckily, the Taliban did give us access to areas that we hadn't accessed for more than 3 years. And we did this big vaccination campaign in November. We vaccinated 86% of the kids that we targeted. And 2.4 million of those children had been in areas where there'd been no vaccination for 3 years. So that's a glimmer of hope for us. COVID-19, a bit of a different story. We haven't had an explosive outbreak in Afghanistan. There's been 170,000 cases. Fully vaccinated, we're only at 10%. So this is a big challenge for us. With all the competing demands, people aren't prioritizing COVID vaccination, but we've got this new partnership to accelerate COVID vaccination in these humanitarian settings. Other areas of work, malnutrition. I mentioned the large number of people that are food insecure. It's estimated that about 50% of kids in Afghanistan are at risk of acute malnutrition. And so we've established 123 stabilization centers for the management of severe acute malnutrition, particularly for those who have medical complications. I've mentioned a couple of times that governance is a big issue, and how you engage with governments that aren't regarded as internationally legitimate is a challenge. So this is a meeting we had with the Prime Minister of the Taliban in early September with his newly formed cabinet. At the head of the table to the left, you can just see his head is Dr. Tedros, who's our big boss. This is the first and to date only meeting by the head of an international agency or head of government with the Taliban's most senior authorities. So the relationship that international governments, that Western governments are having with the Taliban is really just had in Qatar. Those international governments will not invest or give money for any action that falls under the government. So we have to be very careful in our relationships. We're doing this delicate dance with the Taliban authorities right now. We engage and consult them on everything, but we don't let them make decisions about what we do with our money. But they're the only show in town. They're saying, we're the government. There's no one else. So we should be making these decisions. And they've been pretty agreeable to date, but this is starting to change. So trauma. So that's a little bit of a case study there on Afghanistan. Trauma across our region, huge public health and socioeconomic burden. We have the two countries with the highest number of deaths due to trauma in the last 12 months in our region. Afghanistan, over 44,000 deaths. This is World Bank data. This is not WHO data. But 4 of the 10 top are in our region. And as Sarah shared earlier, in Afghanistan last year, over 190,000 trauma cases, in Syria over 226,000. Big operational challenges in addition to the ones that I mentioned before. I mean, managing the complex types of injuries that you get associated with war is just can overwhelm systems, mass casualty incidents. And as you can imagine, as we've said before, capacities and systems are extremely limited. And those agencies that used to provide war surgery in humanitarian assistance have started backing out, like ICRC and MSF doing less than we used to. We have responded in previously in a bit of an ad hoc way. We had a big program during the Mosul operation in Iraq in 2017. An independent evaluation by Johns Hopkins showed that program averted 1,800 deaths. Sarah Halima, who's with us today, ran a program in Gaza in 2018. And again, using a similar methodology, we estimated that up to 1,200 deaths were averted there. So you can do good. I mean, you can deliver, you can get good outcomes. But we haven't been very strategic. And so we've established under Sarah's leadership what the regional trauma initiative, So this is the TOPAT team, the Trauma Operational and Advisory team in our regional office. And our goal is to measurably improve health outcomes due to trauma in humanitarian settings. And it's not just about bringing in big international teams, it's investing in the local capacities. And we have a comprehensive approach from prevention to point of injury through all elements of the health system, right through to rehabilitation. But as we know, in all our settings, emergency, critical and operative care services are very poorly developed, but we see trauma management as an entry point to improve all those different elements of critical and emergency care. And the three pillars of this initiative, the operational support to countries. Sarah's in the field all the time, helping guys do the analysis and do the planning and the programming. Operational research to inform our practice, and partnerships so that we can, leverage the capacities of academic and operational institutions to improve trauma service delivery and trauma outcomes. And that's essentially why we're here. We see Cambridge as a terrific potential partner. Our lessons from the first year of the trauma initiative, there is an enormous number of deaths occurring in the field before people even reach the hospital. And the analysis that Sarah did in Afghanistan, up to 80% of deaths occur pre-hospital, with 27% of those avoidable. Poor systems for surgical and operative care. So having a team approach in the operating room, having a team approach in the emergency department is absolutely vital. We're all aware of the health worker gaps. It's particularly in certain cadres like anaesthetists. And I guess this is data I took from Sarah, who took it from Laura. But, anywhere between 0 and, 1 anaesthetist per 100,000 populations across the countries where we work. And the mass casualty events are common, as we've mentioned. So we really need to focus on that training, build capacities, and we've already done that in 3 countries. Maybe just to shift gears just quickly, I'm conscious of the time. So, we've given you an overview of humanitarian needs and the overall approach, trauma care, COVID. What's happening with COVID in these countries? Well, in our region, we haven't had too many of the explosive outbreaks. We were very worried at the start of the pandemic that it would be these countries in particular that would suffer disproportionately. They haven't had the explosive outbreaks like we've seen in Europe and North America. There's a number of different theories as to why that is the case. But in our region, we've sort of had 5 waves now, like many other parts of the world. But if we look at what's happening in the FCV countries, you can see, on average, the case fatality ratio is up to 4 times higher in our region than the non-FCV countries. The testing rate is 1/20th of what's happening in the non-FCV rate. And the full vaccination, the median's around 10%, as opposed to actually that is wrong. That should be 6%. The median 6% full vaccination. So 1/10 of what's going on in the rest of the region. And why is that? Vaccinations. Well, COVAX, you may know, is this system set up by WHO, UNICEF, Gavi, to ensure that COVID vaccines are available to low, middle-income countries. But most vaccines were bought up by the wealthy countries in the early days of the pandemic. We have not been able to get a substantial number of vaccines to these countries until the last quarter, essentially, particularly in our region. So here we are, into our 5th wave of the pandemic, and now we're bringing the vaccines. So that, what we're hearing from people on the ground is, now you're bringing the vaccines? We've been through this so many times, so we're struggling. We're struggling to get the vaccination rates up in these countries. So let me leave it at that. Just in summary, I hope being able to demonstrate just how severe the burden of emergency needs is globally in our region, and how it's worsening in a very concerning way. Nonetheless, we can still get good health outcomes if we're given access to the people and if we're given the resources. The trauma burden is underappreciated and has a lot of specificities, but we see it as a means, as an entry point to improve broader services for emergency, critical and operative care. And perhaps, you know, we're seeing this today in Ukraine. No humanitarian crisis has a humanitarian solution. These are all political crises at their heart. And we are all at the whims of the politicians who really drive these humanitarian crises. So thanks a lot. Great privilege to be here. And I'm sorry if I went over time.
Thanks so much, Rick. That was brilliant. We're going to have questions at the end via the Q&A functionality on Zoom. So if you save your questions, put them in the Zoom function, and then we'll address them all at the end, and we'll field them from the room at that point. Evening, everyone. My name's Tom Bashford. I'm a clinical lecturer in anaesthesia at the University of Cambridge with a particular interest in global health. And as of September this year, I take up a role as university lecturer in healthcare systems. So you can probably see the overlap of why I'm interested in this kind of work. And since about 2012, I've worked with Cambridge Global Health Partnerships on their Myanmar partnership. And I'm also an honorary advisor to the Tropical Health and Education Trust. So we've been really privileged to have the WHO team with us here today in Cambridge to talk about potential collaboration and how that might work. And it's really nice to hear Rick so warm in his appreciation. There's a load of potential good work. I'd like now to introduce Professor Peter Hutchinson, who is the PI of our Global Neurotrauma Research Group. He's also the Professor of Neurosurgery here at Cambridge, and he's the Director of Research for the Royal College of Surgeons of England. And Hutch is going to talk to you about the academic work that we've started doing in Cambridge since 2017, funded by the NIHR, to look specifically at neurotrauma, building on the pedigree that Cambridge has on sort of neurosciences and clinical neurosciences and intensive care and neurosurgery, but now expanding more into looking at trauma systems, hence the WHO link. So I'm going to hand over to Hutch.
Thanks very much, Tom. And just to add a welcome to our colleagues from WHO. Thank you very much for joining us in Cambridge. It's a pleasure to see you here. I'm going to talk predominantly about neurotrauma, but just a little bit about some of the other global surgery work that's going on through the College of Surgeons. So we're very grateful to the NIHR and the DHSC for the NIHR Global Health Research Program, which was conceived, I think, probably about 7 years ago, and has supported a number of very high quality research initiatives directed at improving health in people in low and middle income countries. If you look at the surgically relevant global health research groups and units, there are currently 5, the largest of which is the NIHR Global Health Research Unit of Global Surgery coming out of the University of Birmingham, which has done a lot of work, particularly in terms of the impact of COVID on surgery. There's a group in Leeds looking at surgical technologies, cost-effective technologies. Examples are gasless laparoscopy and cost-effective orthopedic fixation in terms of locally produced external fixation devices. There's also a group in Imperial that's related to orthopedics, and the Burns group, although my understanding is that this is not going to continue in Swansea. That was Tom Potiker who ran that and has now gone to the International Red Cross. And then we're fortunate in hosting the research group on neurotrauma here in Cambridge with my colleagues, particularly Tom, David Menon, Angelos Kolias, Rowan Bernstein's involved in it, and many of our PhD students. The college itself has a number of global surgery initiatives beyond the NIHR, and we've been very vexed by this problem of some very good academic output. Some really great papers have come out, and we've got some really good data. But I think what the challenge we're facing is how we actually move from academic endeavor to actually influence governments and health ministries to change policy. And the college is recently starting a collaboration with the London School of Economics, a global surgery policy unit. This will have 2 directors, 1 surgeon and 1 economist, and hopefully that will try and address this issue of how we translate beyond academia. The college also have a collaboration with the UK Humanitarian Innovation Hub, including funding a number of UK humanitarian surgery fellows. And what we're trying to do is have a buddy system where there's fellows in LMICs actually buddying with UK fellows to look at important research questions. And then last year, there was a global roundtable meeting, again addressing this policy issue between a number of stakeholders, including the NIHR, DHSC, the NHS Confederation, WHO, the Lancet, who looking at perhaps future commissions, and the college itself. Focusing more on trauma and specifically neurotrauma, this is a map that my colleague Tony Fugagi in Cape Town sent us, and he sees the world the other way up. The world does not have to be the way we see it. It is a globe. It could be viewed either way. And he likes looking at this because a lot of the trauma issues are in India, other parts of Asia, Eastern Mediterranean region, and particularly Sub-Saharan Africa. And I think looking at the world this way up sort of emphasizes that. If you actually look at the numbers, there are around 14,000 deaths per day from trauma on the planet. Many of these are due to head injury. 89% of TBI occurs in low and middle income countries. About 89% of publications come out of high income countries. That's something that we need to change. So we set out with a number of close collaborators through the NIHR Global Neurotrauma Research Group in the countries that are shown on this slide, with academic collaborations with a number of universities. In terms of the NIHR research groups, I think that was regarded as quite ambitious in terms of the number of partners, but then we went beyond that, and in fact of creating a registry that's accessible to any country worldwide. The group itself is divided into 4 themes. Theme 1 is very much about data collection, registries, our GENOS study, the registry GeoTBI, and then some more detailed analysis in Zambia and a program on prevention. So this is, does anybody know who this is? That is Lawrence of Arabia, who died in 1934 on his motorcycle. He was not wearing a helmet. And if you look at advances in neurotrauma, Sir Hugh Kearns from Oxford did a lot of work in terms of motorcycle helmet implementation, Second World War and beyond. And then this is a photograph that I took on a visit to Chennai in 2016. So the car for the people of India perhaps has not been successful as one might anticipate, but when you can get the whole family on a motorbike, they see ways around this. But note that only Dad, sadly, is the one wearing the helmet. So the theme on study, so GENOS, this was a snapshot study of a month of neurotrauma. Again, any hospital in the world was eligible. That's currently in submission, hopefully will be published shortly in Lancet Neurology. But I think more importantly, that will lead on to the GeoTBI. So this is a very simple registry. Again, any hospital in the world will be eligible to put in their data on outcome from traumatic brain injury. It'd be helpful, I think, for their own data collection and improvement local audits. But beyond that, I think we'll be able to build a much bigger international picture of the problems that head injury poses. We focus predominantly on head injury, but as part of neurotrauma, the spine is also included. So we're currently running what we call GENOS Spine. So again, this is a snapshot study. Any hospital in the world, again, eligible to participate. We've had a really good response to this study. You can perhaps, I think the QR code should work from your phones if you want to find out more about that study, or we can send further details. Theme 2. Theme 1 was a very broad brush approach of data collection. Theme 2 is very focused. This was led by Tom Bashford, John Clarkson, collaboration in engineering and colleagues. Really, I'm not going to go into it in any detail because Tom presented it earlier this afternoon, but a systems engineering approach to really map the current pathways of care, look at how changing systems could actually improve those care at the point of implementation. And I'm sure we could pick up more of that in the discussion with Tom. Theme 3 is about new innovation and cost-effective technology, both physical technology, but also guidelines. So this includes stratified guidelines directed at different resource-limited settings, and then actually looking at how we can use new technologies in LMICs. So this is an example. The CT scanner is well recognized in high-income countries, has now become portable. We have the Serotom on the intensive care unit. Certain countries, they're putting the CT scanner in the ambulance. But if we're going to try and improve the detection of hematomas in the brain in other settings, then we're currently piloting the scanner, the infrascanner study ongoing in Colombia, which is showing some success in terms of this handheld scanner can detect hematomas, particularly those near the surface. We're also looking at intracranial pressure measurements. So we usually measure intracranial pressure through an invasive probe. You can get a surrogate of that from optic nerve sheath diameter measurements. You can do that by ultrasound. Ultrasound again can be cost effective. This is the Philips Lumify, a simple probe that is connected to your smartphone for its screen display. It does not need to be a very sophisticated, large, expensive ultrasound machine. This is one of our more recent advances. So this was run by Vicky Warren out of KL. Telemedicine via smart glasses. Again, relatively inexpensive smart glasses. What Vicky did was send the most junior member of the team in PPE with the smart glasses onto the ICU, with everybody else stayed outside. This is the person actually on the unit. And this was actually designed for COVID within one hospital. But what Vicky is actually doing is using this for telemedicine to manage patients remotely in other parts of Malaysia, with the data transmitted live back to the parent hospital in KL. Theme 3 also involves the roles of families. Again, this is work that Tom's been doing. We feel families can play a very important role in the management of patients with traumatic brain injury. They can monitor the state of unconsciousness in patients acutely, but work we're doing in India is actually teaching families to deliver rehabilitation to their own family members. We can teach them, and again, this is looking quite promising. Follow-up is a big problem. Something that we often take for granted here is the postal service. You'll be aware that in many parts of the world, the postal service does not exist. Addresses do not exist. So one of our PhD students, Brandon Smith, has developed this technology to actually get the Glasgow outcome score on a mobile phone, not even an app, but actually digested down to simple SMS text messaging. That's something that we designed for Africa, but actually this may have some benefit to the NHS, and we're currently using this out of the neurotrauma clinic in Cambridge. And finally, theme 4 is about capacity building and how we can build research output across our partner collaborators, and the work of Charlie Whiffin, and the importance of qualitative research in terms of disseminating research protocols, looking at what the inhibitors are, the stimulus, the desensitizers, and the accelerators are to undertaking research in these countries. And an example of that we're particularly proud of, we're running this large international multi-center trial of decompressive craniectomy. So that's an acute subdural hematoma. You undertake an operation to remove the hematoma, and the debate is whether you should put the bone back to restore the integrity of the skull, or whether you leave the bone out, which allows the space for the brain to swell. So that's a decompressive craniectomy. So that is NIHR funded through the HTA program. The biggest contributor to this trial, we're delighted, is our colleagues in Bangalore at NIMHANS, who've put in the most number of patients, really high quality data in terms of the randomization, data collection, and follow-up. So you can deliver these RCTs in low and middle income country settings. So I think the group's had a number of good academic outputs with the 14 partner institutions, and beyond that in terms of the registries. We've supported more than 30 ELMIC PIs and research fellows with over 50 peer-reviewed publications and over 40 national and international presentations. But I think we need to go beyond that. This, as I said, is not about academic endeavor. It needs to be about impact, and the group to advocate at international, national, local levels, and I'll come back to that. The guidelines that are appropriate to the resource and informing national policy in partner countries. We've mentioned training this afternoon. I think that's something really important, particularly in terms of research training, but also clinical mentorship and how we can build research capacity building. What we haven't really touched on today is the medical student elective program in Cambridge, and I think there may be some opportunities with the medical students in terms of some of these projects. We were fortunate I was a delegation of neurosurgeons from the WFNS who represented neurosurgery at the World Health Assembly, and that gave us an opportunity to lobby a number of different health ministries, and I think you just get the feeling that we are beginning to make some progress. And through the work of David Clark, Ricky Trivedi, the number of neurosurgeons in Zambia, for example, is going from 2 to 8. So to acknowledge my colleagues in Cambridge and beyond, too many to mention in detail, but particularly partner countries. This was our launch at Robinson College in 2017. Tom, I'm conscious of the time, so I'm going to stop there, but that's my email address and Twitter. But just to thank you again for coming, and to everybody here for supporting this work.
Thanks, Arch, that was brilliant. And now, if I can just quickly stop the sharing, I'm really pleased to introduce our last speaker, which is Arthur Quizera. So Arthur is an anesthesiologist and intensivist at Malaga National Hospital in Kampala and a lecturer at Makerere University. Arthur has recently completed his PhD between the University of Cambridge and Makerere. And he's going to speak to us about how academic collaboration and operational improvements go hand in hand, and the benefit of North-South collaboration grounded in academia, but then spilling forward into kind of long-term partnerships and operational improvement, and how that looks from his perspective. So hopefully I'm going to hand over to Arthur.
Hello, everybody. Can you hear me?
We can hear you, Arthur. Okay,
thank you very much. I'm sorry I'm not able to be with you in person. I managed to catch some of Cambridge's finest weather. So I'm in a little bit of isolation for a few days. Thank you, Tom, for inviting me to say something about this topic. As usual, a wonderful ambush. So I had to quickly get myself together. I initially said that I would speak, but I think I just decided, let me just create some quick slides to help really guide me tell the story from my perspective. So, just hold on. I hope you can see that. Like Tom said, I'm from Kampala, Uganda. I'm an Ugandan anesthetist and intensivist. A lot of my work is in intensive care. And we have done a bit of work with traumatic brain injuries in our setting. A lot of this work that we've been able to do has been a result of how the North has helped the South build capacity, both in clinical care and research, and I'll share my story. So the first thing, just a historical perspective, because obviously I'm speaking from Ugandan standpoint. Our first ICU was built at the National Referral Hospital in Mulago in the mid-1990s. And it was a renovation of an old sort of high dependence unit that was donated and was donated by the Japanese government. We had 12 beds, and the unit was run by British trained anesthetists who are since retired. And later in northern Uganda, where some of you might know right away, also a British anesthetist opened a high dependence unit. I'll show you an image of that. And then later a private hospital in Kampala. So the first thing that we shall notice is that in Africa, anesthesia, ITU and anesthetics obviously are driven by physician anesthetists. And then the key personnel in probably about 99% of running resuscitation services, emergency care. There may be about six countries that have an emergency medicine program. So as you can imagine, the remaining 48 or so odd countries depend on anesthesia personnel, whether physician and non-physician anesthetists to provide resuscitation and emergency care, and obviously intensive care. In 2007, we only had about 11 anesthetists providing care for 30 million people and one ICU trained nurse. This is in northern Uganda. This was the first, for some of you who've seen the Gloucester event or heard about it. This was the ICU at Lacho Hospital. So typically what would happen is use this in theater, in the OR, and then transfer the patient if they needed mechanical ventilation to the ICU. And I think they did write this up. Majority of their patients, if we are not post-ops, were tetanus patients and snake bite. So my journey, as you can see, there's quite a bit of a strong British influence. I started my anesthetic training in 2006. And in that time, we were still using ether, thiopental, saxamethonium. So you just had those three and you were sorted. Dr. Sarah Hodges was a missionary anesthetist who'd come with her husband, Dr. Andrew Hodges, to set up a cleft palate program. And she was my first mentor. And then later, Dr. Isabel Walker was a visiting pediatric anesthetist from Great Ormond Street Hospital, with who I was doing some clinical work in the theater. I think we were doing a cleft palate. I had just transitioned to halothane, and I used to have trouble, especially where we administered adrenaline. So because we did not have the other antiarrhythmics like lignocaine and so on, I had read up and used magnesium sulfate. And so we had a halothane adrenaline Turkey, and Isabel was a bit puzzled as to what to do. And I said, no, I have mag sulfate. So I ran up to the obstetrics unit, because we used to use mag sulfate for preeclampsia patients, brought it down, gave it, administered it to the patient, and, the arrhythmia was gone. And so she's like, we should write that up. I'm thinking, okay, the concept of writing was not in my mind. And so she actually wrote the whole article. To be honest, I probably contributed my affiliation, and she made me first author. That really did something to me. That inspired me to start, we should, because as you know, Africans are very oratory. We tell our story verbally. We've not been very good at documenting. And so she gave me additional tips in writing. Along the way, Dr. Gerard Dubovitz and Tony Roche, these were from UCSF and UW, but also English. Tony Roche is Irish and South African as well. Helped me get over the line in my master's thesis, mentorship, life coaches. We're still friends today. Ian Wilson brought me over to Harrogate in 2010 to talk about 2009. Talk about supporting anesthetics training in Africa. And so we created this overseas anesthesia fellowship whose domino effect led to the creation of training, and also the drive that helped us build our anesthesia capacity. I then went to UBC for additional critical care cardiac anesthetics training, and through Drs. Randy Moore, Ahmed Umedali, who was born in Uganda and had relocated to Canada. They have since both retired. Mentored me through a fellowship, and then we created a pathway, and I think we've trained about maybe 8 or 9 specialists, both general intensive care, cardiac anesthesia intensive care, pediatric anesthesia and intensive care, and pain medicine. And then Dr. Martin Dunsa, who has since become a long-term friend, basically taught me about how to do research. Now, why am I saying this? Dr. Dubovitz was the first person to tell me that, you don't need to leave the country if you can. Stay, you'll make a difference, and will help you, do the work-life balance thing. And all these doctors who initially came as soul missionaries, or whatever you want to call it, through them started what we would call some sort of revolution. And so, one of the ways was to document the needs of the country. Of course, intensive care was one of the bigger ones. And by writing and publishing this work, the government paid attention. And by paying attention, by documenting the death of intensive care in the country, they said, okay, how can we help? The government stood up, said, okay. So we said, all right, you need to support more anesthetists in training, both physician and non-physician anesthetists, ICU trainees as well. Of course, COVID has played a very significant role, and it's one of the reasons why we have the SCALE critical care program that one of the grand rounds we had this afternoon. So as a result, we've had the benefits of these guys who came over trying to help. And by the way, I've missed out very many. There are many guys who did surgery. We have a very nice new young active pediatric surgery program and others, neurosurgery also with visiting specialists from Duke University. And the knock-on effect is right in front of you. If I didn't know intensive care, if I didn't learn advocacy, if I didn't pick some of the soft skills from a lot of these mentors, a lot of this would not have been shared with other people younger than myself, but also well, with the country would have just been, status quo. So we're now, as you can see, trying to improve intensive care capacity. Of course, it's usually buildings are easier than human resource, but now also paying a little more attention to the soft side of medicine. That's the people. Now we have the Cambridge training initiatives. We have a bachelor's anesthesia program for non-physician anesthetists, and so on and so forth. And collectively, we've had about 60 plus publications. So it's a very big topic, but I thought I'd give Uganda's experience through one man, because many others also have the experiences as to how this can benefit. And now, of course, Tom and I and others have started a new journey in something else, and I hope that we can grow this thing in many ways that will benefit this partnership. Thank you very much.
Arthur, thanks for that. That was brilliant. That kind of told us the story of how academic work can then pull through to government advocacy and drive change. We've got some questions that have come through. So if I could get our speakers just to come and sit at the panel, I think there's going to be a different camera that points at us. And we'll just field those questions. Arthur, if you stay with us and you can chip in as well. So Rick and Hutch and Rowan, do you want to come up and sit in the panel? And then the questions should be, so trying to bring two of them together, they focus on the kind of the pre-hospital element. So one of the questions we've had is about the data of the causes of death in trauma that happen before they get to the healthcare facility. And then the other is about the lack of first response services in low and middle income countries. So Rick, I guess that goes kind of back to the data that you and Sarah collect in countries. So could you give us the insight into what that fraction of people are? What are they dying of, and what's currently being done about the lack of first response?
I'm going to defer the first question to Sarah.
Sarah, why don't you come and sit up here? I think you should. There's an empty space there for you.
Come on.
Oh, I think it'll be good.
Sarah knows the data.
So I'll relay the questions because I'm aware that Sarah's not mic'd up, so it may not carry through to the Zoom audience. So Sarah Halimar is the lead of TOPAT, as you heard earlier. And so the question was about the data on the people who die in the field before they make it to a healthcare facility, and then a brief comment about that lack of pre-hospital, emergency first response in the countries you work in. So if you're able to answer that for the room, then I can relay it for the Zoom audience, just in case they don't know.
Fundamentally, what we've found is that in many of these fragile, conflict, violence-ridden states, data collection is very poor. Imagine being a doctor where you haven't been paid your full salary for about 8 to 10 years. You're working in a context in which there are no equipment, a limited supply of consumables or drugs or medicines. The hospital directors often change quite frequently, and you're constantly feeling quite insecure, under attack, and unable to really provide for your family. In those situations, providing clinical care is your priority, and unfortunately, documenting that clinical care is at the bottom of your priority list. And unfortunately, what happens is being able to then access patient data is very limited. I've worked in contexts where data that's collected is limited entirely to those who have died, and that's only being collected because of the legalities behind it. And beyond that, I think the most that we can sometimes hope for is a name, age, and cause of death. So it's very, very difficult to collect an accurate picture of what's going on the ground. And what Rick presented today was really what WHO has been able to collect along with other agencies, but we know that that's just the tip of the iceberg. With that, in putting that into context, WHO has staff and country offices in many of the countries that we work in across our region. So across those 22 countries, from Morocco to Pakistan, we have healthcare staff working on the ground, trying their very best to collect data. And often that's very, very challenging for them because they cannot access those regions that are most in need. We've been trying to, through that setting, establish surveys, questionnaires, and collate that along with qualitative data, so through focus groups and interviews. So a lot of the data that we've presented on trauma is based on those surveys that have been conducted. The dead on arrival figures that Rick presented today are actually across, are taken from surveys across health facilities, so at the hospital level. So that figure of 60 to 80% DOA rates across all trauma deaths is already very biased, because we know that a lot of people die and do not bother to actually, the relatives do not bother to take them to the health facilities to record deaths. So a lot of deaths are happening in rural and remote communities that we would never know about. So there's a bias in that data, and already we know that that figure is probably skewed. Unfortunately, the focus on healthcare services outside of the facility level has been very limited. For years, humanitarian funding and humanitarian agencies have focused at the hospital level. And so what we are advocating for is to look at what happens at the patient pathway before they reach the facilities. Now, what's happening across the Eastern Mediterranean region is that you don't have pre-hospital care services as we understand them to be in the UK today. To give you an example, in all of South Yemen, you have a pre-hospital care system of only 10 ambulances functioning to this date. In Somalia, there is no pre-hospital care services outside of the main areas of Mogadishu. In Afghanistan, there is no pre-hospital care system, there's no ambulance system. And the vast majority of injured people rely on community healthcare workers or sometimes midwives that have been trained. But beyond that, it's very, very limited. There is no transportation system, there's no paramedical sciences system, there's no paramedics. And unfortunately, in that vacuum, what we are trying to identify is where resources should be placed so that we can have the most impact. The answer to that I cannot give you because we are still exploring that question. And I hope that collaborations with Cambridge will help us to understand better where we can allocate our resources. We are not in the privileged position of being able to develop a comprehensive pre-hospital service across the states that Rick laid out in his presentation. We have to have a targeted approach. So where we put those resources is something I hope that we can ask with our Cambridge partners and others to join the sort of humanitarian agenda. And I think the best approach is to ask the questions along with those local healthcare workers and pilot programs where we can demonstrate results and then have a scalable approach.
Thank you. So that picked up on mics, didn't it? Thank goodness I could not have given that as a press release. That was perfect. Thank you. That leads on in a way.
Because I think the Indian government, and I don't know whether it happened, had this plan for the ambulances every 50 kilometers.
The Golden Quadrilateral.
Yeah,
yes.
Mumbai. So I don't know, because that was I don't know how it went though. That was a few years ago. You may know.
I know that David as well in his work in Zambia had exactly this problem at the facility level. And one of the solutions that he found was to correlate police records with mortuary records with hospital facility data. And he found actually the police records were often the most holistic in terms of capturing, because they were the first responders in the absence of an ambulance service.
Yeah,
so it's exactly the same challenge.
We've also had cases in Somalia where actually when you're injured or you've got a relative that's almost dying, they won't take you to the hospital, they'll take you to the police station. Yep. Because they have to first record the incident before the hospital can even provide treatment. And of course, by the time they reach the hospital, they're dead. But the point is, it's sitting in the police records. Yeah. So it's really complex, the situations that we're dealing with. And I think there isn't a single approach or single solution that can be applied to this problem.
Brilliant. So I think very bluntly, in response to the first question of what's the cause of death before they get to hospital, we don't know. And we don't know because the data doesn't exist. That's fine. And then you've given us a really good outline for exactly where we are with pre-hospital care in a lot of the countries you work in. We've got a question from Nigel Rossiter from Primary Trauma Care Foundation to learn more about the plans for trauma and healthcare services in resource poor settings. I guess the question to you, Rick, is obviously WHO has become alive to the question of trauma. What does the rest of the international humanitarian and development community think about trauma? Is that in the same way that infectious diseases are talked about by many different stakeholders at multiple levels? Do you find that trauma is the same, or are you shouting into a vacuum of people who are busy focused on other diseases?
Yeah, I think it's more of the latter. I think, within the public health humanitarian world, there's been only 2 or 3 agencies that have owned the space of providing trauma care in conflict. ICRC, MSF, more recently, Emergency, Italian NGO that's currently working in Yemen and Afghanistan. But I think for many of the other humanitarian agencies, so I'm an emergency physician. I was the health director of a US-based NGO called the International Rescue Committee for 10 years, from 1999. To get my colleagues interested in trauma, just wasn't going to happen, because I think people don't see the value, in terms of lives saved, cost effectiveness of well-targeted investments in emergency critical operative trauma care. They don't. They think we're going to get a bigger bang for our buck with vaccinations, with child health programs, maternal health programs, reproductive health. So, yeah, I mean, I could give you many stories of bumping up against people who, like, it's too expensive, it diverts resources. But I think some of the evidence base we're trying to generate, we were discussing today that some of the data shows that around 50% of deaths in low middle income countries could be averted with better emergency critical and operative care services. And we were talking about this earlier. We need each element of the continuum addressed: the emergency care, the critical care, the operative care, and we see trauma care as a great entry point to strengthening those different elements of the continuum, particularly in the humanitarian settings where there's a high burden of trauma. But there aren't many of us out there doing it right now, unfortunately.
And I wonder, Hutch, Rowan, does that tally with your experience of things like neurotrauma in the UK 20 years ago? Was it the same debate where you were trying to get people interested in something and essentially generate that evidence and then build the services on the top? Was that?
I mean, maybe I'll speak for neurosurgery, then maybe Rowan. So I think neurosurgery, it's become a recognised subspecialty of neurosurgery now, trauma. And I think 30 years ago, the mortality from brain injury, polytrauma from hemorrhage was terrible. And I think it's many factors that have improved, the major trauma networks, I think collaborative working across specialties. So I think things are better. But there is now a well-recognised number of neurosurgeons. There's a British neurotrauma group, Angelos is part of this, that actually specialise in trauma.
I mean, I think the picture for major trauma and non-neuro major trauma is very similar. I think it took, I mean, Rick alluded to this, it took politics and a whole lot of data showing just how bad the UK was to actually start to drive that whole process. But similar, there's much more research, there's a lot more groups now working on it. And there's really good databases like the TARN database, giving you really good outcome data that you can then build on to demonstrate you're actually making it and having an effect.
And Arthur, hopefully you're still online. How do you think this is in Kampala at the moment? Is there an emphasis on trauma? Is that seen as a growing and emergent need that people are responding to, or is it still a bit of a skeleton problem that people aren't looking
at? I'd like to think we are probably a little luckier. Well, there has been, the surgeons did lead quite a bit of, mostly from a trauma perspective, a resurgence or maybe some intentional focus on this. And then when we set up the two emergency medicine programs that have come out, there's a lot of advocacy driven towards emergency services. And of course, emergency services were driven by trauma. And the trauma was actually road traffic accidents. It wasn't, a cardiac arrest in the office or so, something like that. And so we then created a whole commission in the Ministry of Health. So there's a commissioner for emergency medical services, as well as ambulance services. Of course, there are still some challenges because we are still doing the scoop and run approach. But there are attempts. The Institute of Public Health has a trauma registry. It's not very active, so we get a lot of our trauma data. They mentioned the police, and that's actually very true. We are now starting to slowly move away from data at the police station towards data in the ambulance records. So yeah, that's what we have. I'll just add that our emergency services tend to be more active around festive seasons. So Christmas, holidays, Easter, and so on and so forth. Yeah.
Thank you. That's brilliant. And then a question that occurred to me as the talks went on, Rick, and it's hopefully not too challenging, but it's very easy to be bleak about the picture, because the data you presented and the picture of need with essentially a withdrawal of humanitarian services can be kind of overwhelming. And I wondered if, based on what you've seen, what would be your exemplar of something done well? So when you said, there's that one project that we did and that absolutely nailed it for a whole bunch of reasons. If you can kind of give us the picture of what this looks like when it works and what the key elements of that were, if for nothing else than to end on a note of optimism.
Well, I always try to be optimistic, because I mean, look, I could have shown you a lot of data where we've had impact. In humanitarian health action, we have standards that we aim to meet. And we've got plenty of examples where we've met the international standards. I think the reason I presented Afghanistan is because I think it is a good example. We were on the precipice with that health system just going down the drain with only 17% of health facilities fully functional. But I think because there was agreement from the donors and willingness from us, and UNICEF to step in, we're able to fill that gap. So I think, for me, that was a good example of prioritization and execution. Other examples, the problem with a lot of the good examples, and I would contend the trauma examples that I gave earlier were like the Mosul operation. So the background of that was ISIS was occupying the city of Mosul in northern Iraq. The Iraqi government was planning a major assault to dislodge them. We knew that, and in part of Mosul, it's very much high density. We knew it was going to be street to street fighting. We knew that the civilian impact of that was going to be enormous. So we sent a team in who designed the trauma referral pathway. So we had trauma stabilization posts as close to the front line that moved with the front line. Then behind that, we had a couple of field hospitals. And then behind that, we had the tertiary referral in Erbil. And the trauma stabilization posts did move. And again, Hopkins, there was a lot of cynicism by some of our donors. US government were slamming us on this. This is not the best use of resources. Frankly, we hired a private company that's a non-profit that has a social good as its objective, and they cost us a lot of money, but they delivered, and we averted 1,800 deaths. That was a very well-designed program. It's not for a number of reasons. It may not be something that we can repeat on constantly, but another good example of where we saw a problem, we designed it in advance, and I think again executed. Like perhaps this will be my final comment on this. When you have a camp-based setting where you've got refugees or internally displaced people in a camp, it's very easy to design very good health programs in that sense. And that's where many people in humanitarian health got their start back in the 80s and 90s and so on. And if you look historically at South Sudan and Somalia in the 80s, the cholera outbreak in Goma in 1995, famous, sky-high mortality rates. This is where the idea of international standards for humanitarian action came in. And we established through what's called the SPHERE project, international standards. We turned things around. I mean, we never saw the mortality rates of the 80s and 90s after about 1995. And that's because we know what it takes to set up comprehensive services in a camp. And I could, mention, I've been involved in many camp settings where we just nailed it with the services, and even in Al Hol camp, where a lot of the ISIS brides are right now in North. The health indicators, in spite of a really tough environment, we're meeting international standards. It's an awful place, but we're meeting international standards. The problem is outside of a camp when you've got an emergency that is literally countrywide. So you can have a good operation here and huge gaps there. You can have a good operation there and, however million kids didn't get vaccinated for 3 years in Afghanistan. So while we had parts of Afghanistan that had good access to healthcare, there were huge areas that were not. So, we've moved now into humanitarian situations where we've got countrywide operations and countrywide needs. And then that's hard operationally, and it's really hard for the data management. Yeah. What do you do with data that you've aggregated at national level? I mean, how does that help you target? So, it's a long answer to your question. Plenty of good examples, not consistent enough, much easier in, captive populations or smaller areas, but to demonstrate that at country level is tough.
Yeah, it plays into that in a way. It segues nicely into the next question I was going to ask. So Hutch and Rowan and I have got quite used to working in an academic centre where your evidence-based generation and application to clinical practice is reasonably tightly coupled. And that's how it's meant to work. So you're constantly coming up with problems, identifying things, setting up interventional studies or running trials and trying to grow your evidence base to meet your needs. Where do you see the gap in this kind of trauma in the global south, either the humanitarian or the development phase? We've got it in clinical medicine, but how does it work in what we can call humanitarian medicine? Where's the gap for academic research to support that work?
Yeah, well, I think perhaps, as we discussed today, I think the emphasis in our settings needs to be more on the operational research rather than the interventional research. Yeah. So that would be my first observation. Secondly, I think we probably haven't, we haven't seen the value of hearing some of the stuff that you guys are doing today, pennies start to drop. We've had, I'll be honest, and I was honest earlier today a couple of times, we've had some mixed experience with academic partners recently. I mean, so what we need is we need academic partners who know the operational realities, who can show us how to deliver services better. In an operational context. So some of the system thinking that you got that you're bringing is what we need. We don't need to know, this drug or, this resuscitation, we don't need research on clinical interventions in humanitarian settings. Firstly, it's unethical, in most settings. And secondly, it doesn't matter. We need the operational research to show us how to deliver.
And Arthur, does that chime with your experience in Kampala at the moment? Would you say you were looking more at the clinical intervention research or kind of systems operational research or somewhere in between?
Yeah, I think I'd agree with him. My experience working with the government is they have tended to shy away from when we say, the size tube is better than that size tube, or they want to get the work done. And it's very important to listen to them. The other thing I wanted to mention was the aspect of implementation science. I think that is something that's really new. What are the barriers to to creating change. In Uganda, we piloted non-physician emergency care providers as a way of not task shifting, but task sharing some of these interventions that we're trying to bring in. So I think I don't have the right answer, but something somewhere in the middle. So some interventional work that's done in academic center in a small sample size, controlled environment that gets translated into something that has already been plugged in from an implementation perspective. Yeah.
Brilliant, thank you.
I think there may be this qualitative research, which historically has not been a strength. This may be a very good way to actually address some of these issues.
I think that's right. So I think we're out of time for the panel discussion. Thank you very much. Only remains for me to thank the rest of our panelists. So. And I think I'm right in saying that we've got some closing remarks from the chair of Cambridge Global Health Partnerships, who very kindly hosted this evening and kind of made it all possible. So Catherine Arnold, I'm going to hand over to you.
So just a very few closing remarks from me. I'm Catherine Arnold, as Tom said. I'm the Master of St Edmund's College, which is one of the colleges here in Cambridge University. And as of last year, I'm the chair of Cambridge Global Health Partners. Prior to that, I spent most of my career in the UK diplomatic service. So worked with many different forms of health provider and health intervention overseas, but feel very passionately about the way that many of us in the West take a lot of our health for granted. And it's only when you move in societies or meet communities where that cannot be taken for granted that you realize how much of who we are is based on how healthy we are. And that was one of the reasons that led me to join Cambridge Global Health Partners. I'd just also like to say a very big thank you to Tom and to everyone else who has organized today, to all the panelists and to all the speakers. Today has hopefully been for everyone an opportunity to learn more about the important clinical and academic collaborations within global health partnerships that we see growing and flourishing in Cambridge. Cambridge Global Health Partners itself has a growing track record of successfully enabling this type of collaborative working within health partnerships, with leadership from academic clinicians based in our partner institutions in Cambridge and in low and middle income countries. We know from these leads and their colleagues that academic and research collaboration alongside clinical health partnership activity is necessary as we work together to strengthen health partnerships and systems. Cambridge Global Health Partners was born out of the belief, as I've mentioned already, that health should not be predetermined by where we live. Our mission is to work in partnership to inspire and enable people around the world to improve healthcare globally. Since 2007, we've been strengthening health systems through education, reciprocal learning, and relationship building. We bring an international development understanding and framework to support and strengthen the work of healthcare professionals and academic clinicians. Here at CGHP, we recognize the challenges inherent in global health work and insist on an explicit commitment to ensuring the safety of all those directly or indirectly involved in our work, the effective delivery of our programs, and the very highest ethical standards. As Dr. Tedros, the Director General of WHO, has said, collaboration and partnerships save lives and safeguard societies. In 2020, a healthcare crisis of historic proportions showed us just how closely connected we all are. So as we all emerge from the multifaceted crisis of COVID, at least we hope we're all emerging from it, we are committed more than ever to extend the support that we provide from CGHP to the remarkable individuals and teams in health partnership activities across the world, some of whom have spoken tonight. To provide the support and work in partnership to strengthen healthcare services, we need your help. If you are not already signed up to our network, please get in touch. Committed individuals are our greatest asset. But particularly to those of you online, We are a charitable program and we do need funding to continue our work. So if you've been inspired by what you've heard this evening, please consider making a donation to help us to do more. As a partnership organization, with a tiny core team working tirelessly to support expert volunteers, your donation will be changing lives around the world. Links are being posted now on Zoom and will also be included in the email you will receive after the event, which only leaves me to say thank you very much to everyone in the room and online.